In 1946, Walter Freeman refined the lobotomy into a 10-minute office procedure. No operating room, no surgical team. An instrument resembling an icepick inserted above the eye swept through the frontal lobe. He called it the transorbital leucotomy. State hospitals in the 1940s held over 500,000 patients. Staff ratios often exceeded 1 attendant per 100. Families asked when their relatives would be fixed. Physicians needed something they could do. The transorbital lobotomy answered this. It was fast, portable, required no specialized surgical training. Freeman eventually performed it from a converted van, traveling from hospital to hospital. The results were immediate and visible. Patients who had screened grew quiet. Patients who had fought became docile. Patients who had refused care now accepted it. Medical journals published before and after photographs. Case reports documented marked reduction in behavioral disturbance. The logic was simple. Agitation was the presenting problem. The procedure eliminated agitation. Therefore, the procedure was therapeutic. But the quiet after lobotomy was not the quiet of resolution. It was the quiet of severance. The neural connections that made distress possible also made resistance possible, and planning, and initiative, and emotional range. The patient who might have objected to the outcome could no longer formulate the objection. What was not recorded as harm? Adults who could no longer dress without assistance. Former workers who could not hold employment. Parents who recognized their children but could not respond to them. Individuals described in later notes as present but unreachable. These outcomes were not hidden. They were reclassified. Reduced agitation was the treatment goal. Reduced agitation was achieved. By that metric, the procedure worked. Between 1936 and 1967, an estimated 40,000 lobotomies were performed in the United States. Igaz Moniz, who pioneered the procedure, received the Nobel Prize in Medicine in 1949. This was not fringe practice. This was the leading edge. Lobotomy persisted because it solved the problem it was designed to solve. It reduced institutional burden. It gave physicians an intervention they could perform. It reassured families that something had been done. It produced measurable improvement, measured in behavior, not cognition. The patients who might have disputed the outcome could no longer dispute anything. In the mid-1950s, chlorpromazine became widely available. It achieved the same result: quiet wards, manageable patients, reduced behavioral disturbance. But it was cheaper, scalable, reversible, at least in principle, and it left no visible wound. Lobotomy did not end because the field recognized the harm. It was replaced by a technology that achieved the same quiet more efficiently. The procedure was discontinued. The measurement wasn't. Behavioral compliance as proof of therapeutic success passed from the surgical theater to the pharmacy. The instrument changed. The logic continued.